Greetings from Bangladesh. It's an honor for me to present my country in this platform. It's a great pleasure to present a topic in front of the learned audience. My topic is CABG on CKD patient, a single center experience in Bangladesh. Myself, Dr. MD Abir Tazim Chowdhury, specialist cardiac surgeon, Department of Cardiothoracic and Vascular Surgery. This is the hospital, Evercare Hospital, Dhaka, Bangladesh, where the current study was conducted and my workplace. Before proceeding to my topic, I would like to give a brief background. CKD and cardiovascular disease. Chronic kidney disease, that is CKD, is an independent risk factor for cardiovascular event, and pre-dialysis patient of CKD appear to be more likely to die of cardiac disease than kidney disease. CKD accelerates the atherosclerosis by several mechanisms. This illustration clearly describes how the heart and blood vessels can be affected by kidney disease. There are several pathways how the heart and vessels are involved, which is given in this figure. CKD and its global scenario. Recent studies confirm that the global burden of CKD is high. More than 800 million population currently suffer from this disease. Its prevalence is 1 in 10. What about my beloved country, Bangladesh? CKD and Bangladesh. The seldom studies are available to find the exact prevalence of CKD in Bangladesh. Based on one meta-analysis, which includes 9 studies, a total of 225,000 participants, the study reported that prevalence is of CKD in Bangladesh at 22.48%, which is much higher than the global prevalence. It's really alarming. CKD and CABG. The prognosis for the patient with impaired renal function who undergoes coronary revascularization worsen as estimated glomerular filtration rate deteriorates. Traditionally, hypertension, diabetes, and dyslipidemia are highly prevalent in CKD patients. Incidence and severity of coronary artery disease increase as GFR declines. Risk stratification of CKD patients before CABG would carry a significant clinical implications. It may help to improve the outcomes. CKD patients face additional challenges in the setting of coronary revascularization because in CKD, coronary artery disease has been shown to be diffuse multi-vessel involvement with vascular calcification. Increased comorbidity, reduced use of standard cardiovascular therapies, and more advanced valvular and myocardial disease all account for worse outcomes after CABG. So regarding the coronary revascularization technique, CABG is favorable option compared to PCI, but that is percutaneous coronary intervention. Why? It lessens rapid revascularization, more significant relief of angina, and lengthen long-term survival. So with this background, our study objective was set, and it was to determine the morbidity and early mortality after CABG on patient with CKD. This study was approved by the concerned departmental academic and technical committee. The methodology, it was a retrospective study conducted at Department of Cardiovascular and Thoracic Surgery, Evercare Hospital, between July 2022 to January 2020. There is the period of worsen pandemic, COVID pandemic era. We enrolled 65 isolated CABG patients with CKD more than equal to stage, grouped into dialysis dependent and non-dialysis dependent. This is the selection. The study selected the patient of coronary artery disease who underwent isolated CABG. Study include those patients who are CKD stage 2 or above, elective cases, hemodynamically stable cases, and study exclude stage 1 CKD and those who are emergent case, hemodynamically unstable, having history of acute or recent MI, New York Heart Association functional class 4, and those who are having low left ventricular ejection fraction less than 35%. This is about our study design. We collected all data from our medical record department, assessed population for eligibility were 425. Finally, we enrolled 65 cases. Study explores 360 cases due to not meeting inclusion criteria and incompleteness of data. All the patients' clinical data were evaluated and grouped into diabetic and non-diabetic. All the patients underwent isolated CABG. All perioperative data collected, processed, and analyzed, and then result and conclusion were made. As I mentioned, we grouped into our study population is grouped into two: dialysis dependent, that is 18, and then is not dialysis dependent, where we allocated 47 patients. This slide is about our routine protocol for managing CKD patients who underwent CABG. After admission, we thoroughly evaluated and stratified the risk factors of the patient and planned for management. Preoperatively, we ensure adequate optimization by giving hydration, appropriate hydration, and giving hand acetylcysteine, taking nephrology consultation, adjustment of drug, and giving dialysis those who are dialysis dependent day before surgery. On perioperative care, all the patients were underwent on-pump CABG, maintain or perfusion pressure during cardiopulmonary bypass was more than equal 80 millimeter of mercury. Mannitol not used in dialysis dependent on and those who are anuric patients. Cough and muff used for dialysis dependent patient, and during that time target hemoglobin was we ensured more than 10 gram per deciliter. Postoperatively, we ensure adequate and appropriate fluid management for those patients, adjust our drug according to need, give erythropoietin in those patients who are anemic, not having good hemoglobin. After taking consultation from hematologist and nephrologist, give dialysis on first PUD those who are dialysis dependent, and ensure early rehabilitation. Our operative techniques, all the patients I already mentioned that on-pump CABG done using mild hypothermia. Conduit of choice was left internal mammary artery and great saphenous vein. We hemofiltration given those who are dialysis dependent patient. This is the illustration where perioperative we provide ultrafiltration. The left side is one is the conventional method of ultrafiltration. However, right side is the modified method of ultrafiltration. During the cardiopulmonary bypass, we provide conventional method of ultrafiltration. And at the weaning time, on when the cardiopulmonary or extracorporeal circulation is stopped, then we provide this modified method of ultrafiltration. Notice that the fact that the patient of extracorporeal circulation, the blood is aspirated from the aorta, runs through the hemoconcentrator and returns by venous line of the patient. Thus the filtration was done. Hemodialysis and hemofiltration. Preoperatively, we provide only those who are dialysis dependent patient day before surgery, I already mentioned. And perioperatively, we give hemofiltration only for dialysis dependent patient, use conventional ultrafiltration and modified ultrafiltration, target hemoglobin more than 10%, target mean arterial pressure around 80 millimeter of mercury. Avoid use of mannitol for those who are anuric patients or dialysis dependent patient. We give in postoperative period, on first postoperative day, we give hemodialysis, intermittent hemodialysis. Though this helps to excrete anesthetic agent, inflammatory mediator, and metabolic waste product. Sorry. Now I am revealing our study result. In current study, as I mentioned earlier, out of 425 isolated CABG cases, 65, that is 15% CKD patients were enrolled. Of them, 28% were dialysis dependent and 72% were not dialysis dependent. This is our preoperative variable. Regarding preoperative variable, majority of the patients were male, over 60 years old, had New York Heart Association functional class 2 or 1, ejection fraction more than 40%, and having had triple vessel disease, most of them. However, the comparison between the groups were not significant. Preoperative variable regarding coexisting factor, all the patients are suffering from hypertension and dyslipidemia, and 85% patients were suffer from diabetes mellitus, and 60% were suffer from the carotid artery stenosis and peripheral arterial disease in mild form. Paraoperative variables, 85% cases we put 3 or more conduit. However, 80% cases cross-clamp time was 60 to 70, in between 60 to 70 minutes. And 95% cases we use left internal mammary artery, and 80% cases incision to closure time is less than 5 hours. However, this comparison between the groups were not statistically significant. Regarding postoperative variables, 85% cases ICU stay, overall ICU stay 2 to 3 days. However, dialysis dependent, comparison between dialysis dependent and non-dialysis dependent, it shows that mean stay in case of dialysis dependent is 5.2 plus minus 2.1 versus non-dialysis dependent 2.1 plus minus 0.8. P-value was statistically significant, less than 0.05. Regarding removal of the chest drain tubes, as you know that after cardiac surgery we give a chest drain. Overall day is 75% cases 3 days. In case of dialysis dependent, it was 6.11 plus minus 0.90, whereas in non-dialysis dependent it was 3 plus minus 1. P-value is less than 0.05. None of our case underwent reopen. However, regarding blood transfusion, we give 2 or more units of blood transfusion in 15 cases. Regarding hospital stay, 90% cases overall hospital stay is 9 to 11 days. Regarding comparison between dialysis dependent and non-dialysis dependent, third mean with the standard deviation in case of dialysis dependent is 13.3 plus minus 0.7. In case of non-dialysis dependent, it was 9.2 plus minus 0.2. P-value is found statistically significant, less than 0.05. Other postoperative variables like respiratory complication found in more in dialysis dependent patient, that is 11.1% versus 8.5%. Mild alterations of liver function seen in dialysis dependent 0.3% versus non-dialysis dependent 4%. Reintubation were 0. Hypoalbuminemia is seen in 10% cases in dialysis dependent patient. In case of non-dialysis dependent, it was 3%. Sepsis found in 2 cases in dialysis dependent and 3 cases in non-dialysis dependent. Morbidity and mortality, other factors like arrhythmia and heart block. In dialysis dependent, we found 33% cases of arrhythmia, and in non-dialysis it was 12%, mostly F. No heart block were seen in our study. All the arrhythmia were controlled prior to discharge. Perioperative MI or stroke was nil in our study population. AKI was nil. Surgical site infection and mediastinitis, 2 cases of superficial surgical site infection found and 1 cases of mediastinitis in case of dialysis dependent patient. Only 1 case of mediastinitis with features of congestive cardiac failure patients, which was dialysis dependent, readmitted within 1 month. No in-hospital mortality in our current study. Overall morbidity and mortality in case of our 425 patients overall. That is, readmission was 0.3%, less than 5 patients were readmitted within 1 month of discharge. Mediastinitis was a single patient, and that was dialysis dependent patient. And overall mortality were 8 patient, that is 1.8%. Fortunately, none of our dialysis dependent patient or CKD patients were demised during this study period. We follow up at 6 months. Found that symptomatic relief of New York Heart Functional Classification 3 to 1 or 2, except 2 dialysis dependent patients. improved ejection fraction in 80% cases, improved creatinine clearance in non-dialysis dependent patient. Frequency of dialysis dependent dialysis were reduced in 10 cases, increased in 3 cases, unchanged in 5 cases. So after revealing our study result, we can summarize a few points. So choice of coronary revascularization, CVG or PCI. We recommended CVG for multivessel disease. No significant difference in operative death, MI or stroke, lower risk of rapid revascularization, which is some study reported that, and a lower 5 years mortality rate, and the composite of death and or myocardial infarction compared to PCI. Conduit of choice, we prefer single internal thoracic artery, Lima. However, some studies showed that bilateral internal thoracic artery not higher risk of mediastinitis. Off pump or on pump CVG, we perform all patients on pump CVG. It improved long-term outcome after CVG and complete revascularization. So there are some few articles. This one is a review article. Title is Coronary Artery Bypass Surgery in End-Stage Renal Disease. The study, in this study, CVG was associated with lower risk of rapid revascularization. Major adverse cardiac and cerebral events free survival was higher in CVG group. Regarding perioperative factor that may associated with morbidity and mortality in heart disease, hemodialysis dependent patients, in current study, variables were correspond with this study. Regarding off-pump versus on-pump surgery, in this study, they showed that there is no extra benefit in case of off-pump beating heart surgery. However, there's some data that showed that improved long-term outcome patients undergoing on-pump CVG. This may be due to the difference in complete revascularization rate, where on-pump CVG is associated with more anastomosis and higher rate of complete revascularization. The superiority of off-pump CVG in long-term outcome has not proven. This article is the oldest one, where they recommended the use of ultrafiltration intraoperatively during extracorporeal circulation and after post-cardiopulmonary bypass to improve the post-operative outcome, which we did in our center. This is another article, Simplified Management for a Hemodialysis Dependent Patient Undergoing Cardiac Surgery. This article more or less to current study. It's a retrospective study conducted on hemodialysis dependent patient. Their strategy were almost similar to our study. They concluded their study with a note that intermittent dialysis can be safely performed for hemodialysis dependent patients undergoing CVG. This one is another single center randomized trial, intraoperative zero valence ultrafiltration during cardiopulmonary bypass for patients with impaired kidney function undergoing cardiac surgery. They concluded that zero valence ultrafiltration bypass filtration during bypass surgery is associated with significant reduction in morbidity and biomarkers of cardiopulmonary bypass induced acute kidney injury soon after cardiopulmonary bypass, which are indicated for clearance of inflammatory and immunomediators from the extracorporeal circulation. This article, another article where they used N-acetylcysteine for CKD patient, which is also preferred and found effective to prevent AKI. In this article, they conducted on larger study population, revealed that the dialysis dependent patients were more vulnerable to mediastinitis and stroke. So near the end of the presentation, I would like to conclude my study finding with a few comments and recommendation. Advance in medical therapy, it extends the lives of patients despite the high prevalence of comorbidities associated with advanced age and cardiovascular events. Referred to surgery, that is CVG, more high-risk patients, including patients undergoing hemodialysis who require coronary revascularization. Complete revascularization coupled with optimal medical therapy for treatment of the underlying vascular pathology are necessary to to improve outcome in patient with CKD. These are a few recommendations. Early identification and treatment is necessary for CKD patient. Cardiovascular risk stratification for CKD patient is mandatory to prevent cardiovascular adverse event. Timely coronary evaluation will also reduce ischemic events and their related complication. Whenever significant carotid coronary artery disease is detected in a CKD patient, early effective coronary revascularization have to lengthen the life. However, another I would like to recommend another point is that the current study was a single center study on a small study population. So a study should be conducted in a multi-center larger population to establish more significant study result among the local population. This one is a renowned New Zealand rugby player who are suffering from the chronic kidney disease due to the nephrotic syndrome, who passed at the age of 40 years due to cardiac arrest. So I want to finish my talk with quoted Sir Winston Leonard Spencer Churchill's words, that is, the healthy citizens are the greatest asset any country can have. As a physician or surgeon, our target should give our service to the patient to make them healthier life so that the country will run smoothly. There's a few references. So you can contact me through this media if you have any question or query. Thank you very much. Thanks for patient hearing.
Thank you so